Hello, 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 hello.
हेलो।
हाँ सर, अभी आ रहा है।
हाँ, आप क्या मेरी आ रही है आवाज?
हाँ हाँ, आपकी आ रही है सर। हाँ
बस तो ठीक है, आप एक बार अपना वो बंद करिए, मैं इंट्रोडक्शन देता हूँ।
ठीक है
आप
सर।
जस्ट लॉग ऑफ कर जाइए, मतलब ये प्रेजेंटेशन बंद
स्टॉप
कर
चले।
दीजिए अपना।
ठीक है सर, ठीक है,
जी।
ओके सर। सर कर दिया मैंने।
हाँ ठीक है, एक सेकंड, जस्ट 1 सेकंड।
ओके।
Good evening, everybody. Welcome to this evening episode of Pursue, and today we have Pursue 6I, which is liver and GI pathology, and we are streaming live from IMS-BHU via Kolkata. And today we have with us Dr. Ojas Gupta, who is an MBBS from Kolkata and MD from PGI Chandigarh at DNB. He did his senior residency in PGI Chandigarh. Along with that, he did his PDCC in Renal and Transplant Pathology. Presently, he is an assistant professor in the Department of Pathology at IMS-BHU Varanasi. He's got several publications in index and national and international journals. And today he'll be talking on the topic, which is non-neoplastic and neoplastic lesions of the oropharynx and esophagus. Before I ask Dr. Gupta to speak, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Ojas Gupta sir, please share your screen and start the presentation. Yeah, just share your screen, please. Yeah, I can see your screen coming. Yeah. Please make it full screen.
Yes sir. Is that fine sir?
And just remove that pop-up hide. Just press on hide. It will go away. Press
Okay.
on hide. Yeah.
Yes, sir.
Yeah. Please start. Thank you.
Okay. Good evening all, and thank you so much sir for your generous introduction. So today I'll be dealing with telling about neoplastic and non-neoplastic pathology of oropharynx and esophagus. So I thank my alma mater PGI Chandigarh, all their respected teachers who with by whom I am here, and my current affiliations IMS-BHU. I sincerely thank to all my respected teachers. So this topic I have taken the content from these books and some journals and CAP virtual lectures. So I'll start with the pharynx. So pharynx is a 12 to 14 centimeter long. It's a muscular membranous tube. It extends from the base of the cranial to the lower border of the cricoid cartilage, and thereafter it becomes continuous with the esophagus. It has three functionally and structurally distinct subparts. The blue one is a nasopharynx, then comes the oropharynx, and then comes the laryngopharynx or a hypopharynx. So oropharynx, which I'll be dealing today, extends from soft palate to the tip of the epiglottis. In the oropharynx, the structure which are included are palatine tonsil, base of the tongue, including lingual tonsil, soft palate, uvula, and pharyngeal wall. So, little bit about normal histology. So, the oropharynx has a stratified non-keratinizing squamous epithelium, and it may contain scattered sebaceous glands, melanocytes, and Merkel cells. The submucosa, which we can see, contains scattered lymphoid aggregates and some prominent uh, submucosa seromucinous glands of minor salivary gland. So coming to the most important organ of this region, that is tonsil. So this is a gross photograph of the palatine tonsil, which has got crypts which are appreciated by these arrows. On histology, we can see that these crypts are lined by stratified non-keratinizing stratified squamous lining epithelium, and these crypts invaginated. Just beneath these crypts lies the lymphoid nodules, lymphoid aggregates, which are better seen in this higher power view. Now the demarcation, these crypts are lined by these basaloid looking epithelial cells which are non-keratinizing squamous, and the demarcation distinction between these epithelial layer and the underlying lymphoid tissue is indistinct, and there is breach in the basement membrane, and this lymphoepithelial kind of structure is called fenestrated tonsillar structure. The similar kind of structure can be seen at other areas. However, if there is any keratinization within these crypts, it should not be confused with the squamous cell carcinoma. So it should be looked in the low power itself, the normal morphology, histology of these tonsils. So let's start with the, after this normal histology, let's start with the non-neoplastic lesions. So first starting with the congenital, most common one is the dermoid cyst. So it's a benign developmental cyst. So in the head and neck region, the most common one is the dermoid cyst. The other differentials are teratoma, epidermoid cyst or tricholemous cyst. In case of epidermoid cyst or epidermal inclusion cyst, these are lined by stratified squamous lining and filled with the keratin. However, there is no adnexal structure. Whereas in case of dermoid cyst, the cyst wall is lined by stratified squamous lining and there will be presence of adnexal structures in the form of sebaceous glands. The other differential is tricholemous cyst, which will be lined by stratified squamous lining, and there will be abrupt change from epithelium to the underlying eosinophilic keratin in the lumen. The treatment is simple surgical excision for these. Apart from this, there can be heterotopic epithelium can be present in this oropharynx. So heterotopia is something normal structure at an abnormal location. So like there can be gastric epithelium, odontogenic epithelium or nerve tissue. So, and these should not be confused with any malignancy because of they can be seen with their benign nature, and these are most common in the earlier part of their life. Other organ is juxtaoral organ of Chivets. It is present within the soft tissue overlying the angle of mandible and the buccotemporal space. It is composed of epithelial parenchyma, which is embedded in a highly organized connective tissue stroma, which is rich in nerves and sensory receptors innervated by buccal nerve. They have got metabolic mechanosensory function, and they can be misinterpreted as perineural invasion in case of squamous cell carcinoma. Now coming to the inflammatory diseases, so the most common ones are tuberculosis in our country. So it can be in the tongue, usually present in the form of painful ulcer. They are usually always associated with advanced pulmonary diseases, and microscopically, characteristically, they will have typical tubercles. Other common entity is syphilis, which produce a gamma-like lesion in the tongue or palate. They appear grossly as a painless indurated mass, and microscopically they will be having granulomas with giant cells, numerous plasma cells, and prominent vascular structures. So after non-neoplastic, let's move on to the neoplastic pathology. So in this category, I'll start with a case. So we have a Master A who's a 12-year-old. He presented with a fever, chill, sore throat, and fatigue for 10 days. On examination, he had bilateral enlarged tonsils with white exudates. He did not respond to antibiotics. On peripheral blood examination, he had lymphocytosis, few atypical lymphoid cells, around 5%. And because of non-responding to antibiotics, a biopsy was done, and it was found that a lymphoid structure was seen, which was having these lymphoid follicles with the nodal architecture was maintained. However, the lymphoid follicles were separated by expanded interfollicular region. On going to higher power view, we saw that there are polymorphous population of cells which were comprising of these smaller lymphoid cells, plasma cells, some larger centroblast and immunoblast like cells, and there were some multinucleated cells as well. So with this morphology, we thought of Hodgkin's lymphoma, so we performed a Barrett stain. However, it was positive in all the small lymphoid cells as well as the larger cells. So with this, a diagnosis of infectious mononucleosis was made. So infectious mononucleosis can be confused with the lymphoma. So let's see how to differentiate these. So infectious mononucleosis usually presents in adolescent or young adults, whereas lymphoma is seen most commonly in elderly. The location of infectious mononucleosis is extranodal lymphoid tissue like Walder rings or cervical lymph node. Lymphoma can present in lymph node, most commonly in the lymph node. Extranodal lymphoid tissue can also be affected. The symptoms of IM are usually fever, chills, sore throat, and fatigue, whereas lymphoma will have B symptoms, that is fever, chills, and night sweats. On careful examination, here the tonsils will bilaterally enlarge, erythematous, and have whitish exudates over them. And in the peripheral blood, there will be lymphocytosis with presence of atypical lymphocytes. The liver enzymes are raised, and EBV on serology will be positive. In lymphoma, we see large lymph nodes which are typically non-tender, whereas in case of infectious mononucleosis, they are tender and they are bilateral, whereas in lymphoma, there will be unilateral enlargement. The etiology in most of the cases in the case of infectious mononucleosis is Epstein-Barr virus, and in case of lymphoma, some entities can be EBV related, like DLBCL and Hodgkin's lymphoma. In case of infectious mononucleosis, they are usually supportive treatment is given and they have got a very excellent prognosis. So it is very important to differentiate between infectious mononucleosis and lymphoma. In histology, as we have seen that there will be in IM, there will be lymphoid hyperplasia with expansion of interfollicular regions, and on ISH for EBER, it will be characteristically positive in both small and large cells, whereas in lymphoma, it will be only positive in the atypical cells. So this is one of the example of lymphoma, where is the diffuse effacement of the nodal architecture, and the architecture is replaced by these sheets of atypical cells, which are better appreciated on this higher power view. So let's move on to the W with this, moving on to the WHO classification of tumors of the oropharynx. So it has the most common entity, that is squamous cell carcinoma, which is HPV positive and HPV negative. Salivary gland tumors, the most common among them are pleomorphic adenoma, adenoid cystic and polymorphous adenocarcinoma, and the hematolymphoid tumors, which includes Hodgkin's lymphoma and other non-Hodgkin's lymphomas. So this is the TNM classification of these carcinomas of oropharynx. So in case of head and neck tumor, it is the status of the lymph node is very important. So like here, the size of the lymph node is very important, whereas in other locations, just number of lymph nodes become important, whereas here size has become very important. This we will deal later on in coming sections. So a bit about grossing of the oropharynx and the head and neck region. So what is the aim of the grossing in these regions? So the first should be, and before proceeding to grossing, we should look at the clinical features. We should look at the radiological findings. What is the site of the lesion? What is the size of the tumor? What is the extent and dimension of the tumor? And then we should confirm the diagnosis on grossing. The aim should assess the status of the surgical margins, confirm the size of the tumor and their extent, involvement of adjacent structure. Choosing a plane of dissection, this is very important. It should run along the parallel to the imaging line, and taking photographs of the specimen and all slices. So the basic steps are identifying the specimen, bearing structures which are forming its part, gross the visible tumor with its size and measurement, and slicing the specimen should be done perpendicular to the natural mucosal surface, recording the size for their thickness, the presence of tumor, and in which section the tumor reaches the greatest thickness, and where the tumor comes closest to the surgical margin. And in case of bony like maxilla or mandible, bone decalcification is important. So the first one is the lesion on the buccal mucosa, where we receive a specimen like this. So this is the mucosal surface. So we have to paint the edge of the mucosal surfaces, and then we should take section like this, and then we should submit. In case of oropharyngeal, that is which is involving here palatine tonsil and uvula, the specimen we will receive like this, and we should cut it like this. Before cutting, we should paint all the margins, and after cutting, we should see the extent of the tumor, and we should take the mucosal margins separately and the other margins. if included. Similarly, if a tumor is present in the lower lip, like in this case, so we can receive a wide local excision specimen. We should paint these margins and then we should serially slice them and then we should take sections from them. And in case of presence of tumor in the base of the oral cavity, we should where the mandible and teeth will also be present. So we should take sections along this. So for doing this, we can need a bone saw to cut these, and the soft tissues can be cut with normal blade, surgical blade, whereas the bony and tooth structure has to be cut with a bone saw. And before that, the margin has to be inked, and the surgical and the whether the adjacent bone is involved or not, we should see these. Similarly, if a tumor is present in the mandibular bone, we should first take the sections at the periphery and then we should cut in between so that we can see the maximum extent of the tumor in the mandible bone. Similarly, in the maxillary region, we should cut the sections and we should paint it and then we should see. In case of radical dissection of the maxillary sinus along with the oral cavity, we should take sections like this. And the mucosal margin becomes very important because tumors in this region are squamous cell carcinoma, like squamous cell carcinoma. They usually spread through the mucosa. So we should separately paint the mucosal margins and then the bony margins and adjacent structures like soft tissue and overlying skin. So let's move on to case number 2. So now this is a 53-year-old gentleman. He had a good socioeconomic status and presented with right neck swelling of around 3.5 centimeters since 2 months with significant loss of weight. He had a low-grade fever. There was no contact history of tuberculosis. On examination, we found that he had a right cervical lymphadenopathy and no other obvious swelling in the body or head and neck region. In routine examination, CBC showed mild increase in lymphocytes. There were no blast or atypical cells, and blood culture was sterile. A lymph node biopsy was performed, and on the section we found that the lymph node was involved by a tumor, so there was metastasis. However, this metastasis was showing cystic change. So the tumor cells were lying in the periphery, and the cyst was filled with some necrotic material. And this is the preserved nodal architecture. On higher power microscopic examination, we found that these cells were non-keratinizing squamous cell carcinoma, and to know the exact primary site, we performed P16 immunostain, and it shows strong and diffuse nuclear as well as cytoplasmic positivity. And a report was given as metastatic oropharyngeal squamous cell carcinoma associated with high-risk HPV. So this is the second entity. So let us see the comparison between HPV positive and HPV negative oropharyngeal squamous cell carcinoma. So HPV positive squamous oropharyngeal squamous cell carcinoma, they present early, than in case of HPV negative ones. They are associated with sexual behavior, whereas negative ones are associated with smoking and alcohol abuse. The lymph node metastasis is frequently cystic in case of HPV positive, whereas it is not cystic in case of HPV negative. The postulated origin of this HPV positive oropharyngeal carcinoma is reticulated epithelium of the invaginated crypts, whereas in case of HPV negative, it is surface epithelium. Dysplasia in the adjacent mucosa is rarely seen in case of HPV positive, whereas it is frequently present in HPV negative cases. Morphologically, HPV positive are non-keratinizing squamous cell carcinoma, whereas negative are conventional squamous cell carcinoma. Keratin is not at all applicable in case of HPV positive squamous cell carcinoma, but it should be done in HPV negative cases. And for P16 immunostain, they are strongly positive. HPV positive and HPV negative squamous cell carcinoma are negative. The HPV positive have got a better overall survival, like 82% for 3 years, and whereas negative ones are 57% for 3 years. So again, this is a comparison of HPV positive and HPV negative oropharyngeal squamous cell carcinoma. So this is the normal tonsil with tonsillar crypt having reticulated epithelium, and the HPV positive oropharyngeal squamous cell carcinoma, they arises from these reticulated epithelium. We can see that there is abrupt formation of the squamous cell carcinoma, and the adjoining squamous layer is not showing any features of deskeratinizing squamous cell carcinoma, and there is some degree of dysplasia present in the adjoining mucosal layer. This is another diagram, panel of photograph to show the similar findings. So for P16 immunostaining, normally tonsillar crypts will show strain positivity along the squamous lining, whereas in case of HPV positive squamous cell carcinoma, there will be strong and diffuse positivity in the tumor cells. So these, now let's go on to specific to this entity. So these are epidemiologically, pathologically and clinically distinct form of head and neck squamous cell carcinoma. They're usually seen in male white of high socioeconomic status. Their median age is 50 to 60 years with a preponderance in male. So they are they are caused by high risk HPV type 16 in more than 90% of the cases, and oral sex is established as a risk factor for them. So they are less likely associated with smoking. However, smoking play a very significant role in the progression from oral HPV infection to oropharyngeal squamous cell carcinoma, which are HPV associated. These are usually localized to the base of tongue and palatine tonsil, and clinically they usually present at an advanced stage with small primary tumor with nodal involvement having most commonly cystic change, like we see in this case. Macroscopically, they are small tumor with large and cystic nodal metastasis. On histopathologically, they will be having distinct non-keratinizing morphology. They arises from the crypt epithelium, grows beneath the surface, and they are present in the form of nest and lobules, often with the central necrosis. They will have high NC ratio, basaloid-like morphology, and high apoptotic rate. And they will be strong and diffusely positive for P16 immunostain. So morphologically, they can be in the form of papillary, adenosquamous, lymphoepithelial-like sarcomatoid small cell, which has got a burst clinical behavior, and basaloid squamous cell and ciliated cell. So for HPV detection, molecular assay, like in case of cervical cancer, can be done by ISH or PCR based. However, strong and diffuse immunoreactivity for P16 also is a reliable surrogate marker if for in case of high risk HPV of oropharyngeal carcinomas. But and it is also sufficient as a standalone test in case of HPV status of the tumor with appropriate morphology. That means if there is not keratinizing squamous cell carcinoma at this distinct location and we get P16 positivity which is strong and diffuse, then it itself alone is a strong can indicate that it is HPV associated. Even loss of P16 expression is also considered as a indication of high risk oropharyngeal squamous cell carcinoma. So when there is loss of P16 expression, so that means there is separate clone of the protein, separate protein clone is secreted, which is not detected by the ones for which IHC we are using. So then additional test for this virus is done in the form of ISH or PCR based assay. So let's see how this HPV causes oropharyngeal squamous cell carcinoma. So this is reticulated epithelial cells in the crypts, and this is the HPV which then enters into the cell. The HPV infection occurs, then HPV DNA gets integrated into the human DNA. Then there will be viral transcription and there will be formation of E6, E7 mRNA. These E6, E7 mRNA, they specifically target P53 and RB protein. So what this E6 causes increased telomerase expression. It causes inhibition of P53, which is the guardian genome. It causes apoptosis of all the cells which have unstable DNA content. The HPV E7, it causes inhibition of P21 and RB protein. So how this? So basically, high risk HPV types, its causes is express oncogenic protein E6 and E7, which combat cellular senescence by increased telomerase expression. It inhibits apoptosis by P53 inhibition. It causes activation of the cyclins. So P21, it causes increased cyclin D dependent kinase and cyclin D increased activity, which cause inhibition of the retinoblastoma protein. So these retinoblastoma protein are responsible for G1 to S phase transition of the cell, and these are inhibited by cyclin D dependent kinases. So when there is a hyperphosphorylation, so this RB protein and A2F will be separated. And normally, what happens normally when there is so in case of cancer state, the cell will move from G1 to S phase. So there will be transcriptional activation. Whereas in case of inhibition of RB gene, again this will happen, and due to this, uh, there is back pressure. So what happens basically? The tumor cells are progressing from G1 to S phase, whereas P16 protein, which wants to inhibit the cyclin D and cyclin D dependent kinases, but in such it is unable to do, and so there is increased expression of P16 protein. That's why in the malignant cells we see the overexpression of P16 protein. So P16 is a tumor suppressor protein which is encoded by cyclin DK dependent gene. It prevents progression from S into S phase of the cell cycle. It inhibits cyclin D dependent kinase protein kinases, therefore maintaining retinoblastoma in hypophosphorylated state. But in case of tumor, it is not able to perform this. So coming to the genetic profile of this oropharyngeal squamous cell carcinoma, so HPV oncoprotein, as we have seen, that E6 and E7 inactivate P53 and RB by targeting them for protein degradation. Other mutations which are seen are somatic mutation TRAF3, which is an immune regulator, which are unique to this oropharyngeal squamous cell carcinoma. Oncogenic PIK3CA mutation or gene amplification is also significantly more common in case of OPSC HPV. So they have got a significantly better survival outcome, and they are tempered only by cigarette smoking. And the risk of tumor recurrence and development of second primary malignancy is also lower in comparison to others. So there are centers where P16 HPV testing when it is not available. So in that case, oropharyngeal squamous cell carcinoma can be diagnosed as squamous cell carcinoma, HPV status unknown. Or if a tumor show characteristic non-keratinizing morphology, then bottom line should be given as squamous cell carcinoma, HPV not tested, however morphologically highly suggestive of HPV. This is a photograph of Varanasi. So it is famous for so many temples, and this is from one of the ghats. So you can have a good scenic view. Okay. So after HPV positive, let's move on to HPV negative, oropharyngeal squamous cell carcinoma. So they occur usually in older individuals, and they are etiology is smoking, alcohol, and smokeless tobacco, like betel quid, which is very common in North in India. They are usually located in the soft palate, and the clinical features are sore throat, difficulty in swelling, neck mass. Microscopically, they look like firm infiltrative tumor with a tan or white cut surface. Histopathologically, they typically exhibit differentiated squamous features, that is keratinization, desmoplastic stromal reaction, and surface dysplasia. And histologically, grading is important for them. They are HPV negative, and TP53 is common gene mutation which is seen in them. Prognostically, they have a poor overall survival. Other rare entities of oropharynx are salivary gland tumors, which usually originate from the minor salivary gland. So first is this pleomorphic adenoma. It's a benign tumor. It has variable cytomorphological and architectural manifestation. It is comprising of epithelial, myoepithelial, and stromal component. It is localized in the base of the tongue, tonsil, and adenoids. So the epithelial cells are present in the center, and which are followed by myoepithelial cells, which are surrounded by the stromal component, chondromyxoid stroma. So they have a mutation in PLAG1 or HMGA2 mutation commonly seen. They are slow growing mass. They present with mild dysphagia. Histopathologically, they arise from the minor salivary gland, and in such cases, they are more cellular and have less predominant stromal component in comparison to the ones which arise from the major salivary gland. So they have complete excision is generally curative, and recurrence due to microscopic satellite lesions. Recurrence can occur due to microscopic satellite lesions, and myxoid variants have got a higher recurrence rate. So other rare entities, adenoid cystic carcinoma, these are malignant. They usually occur in the older age group. and they are rare in the oropharynx. They are present with swelling without numbness or paresthesia or pain. They have a facial and tongue present with facial and tongue weakness. Macroscopically, they are firm grayish white unencapsulated with infiltrative margin. Necrosis and hemorrhage suggest them to be a higher grade. Histologically, they are composed of epithelial and myoepithelial cells, and they are commonly seen in the characteristic tubular or cribriform form. When present in solid form, they are very aggressive. So these tumor cells show scant cytoplasm, typical small angulated, and on IHC, the very characteristic is perineural inclusion, which is virtually seen in almost all of the cases of adenoid cystic carcinoma. On IHC, the inner epithelial cells are highlighted by CD117 and P63 stains for the peripheral myoepithelial cells. They are having translocation 6-9, MIB and MIB-L1 oncogenes, and they have got a poor prognosis. The 10-year survival rate is 50 to 70% with local recurrences. So finally, in case of oropharyngeal cancer, what things should be included in the report? The procedure, what is the procedure is done, what is the tumor site, tumor laterality, left or right, tumor focality, unifocal or multifocal, tumor size, histological type, whether it is HPV-associated squamous cell carcinoma or not, and whether it is the tumor of other minor salivary gland or neuroendocrine tumor. Histological grade is to be given in case of HPV-negative squamous cell carcinoma only, that is 1, 2, 3, well differentiated, moderate, and poorly differentiated. Tumor extension, margins, whether they are involved or uninvolved, lymphovascular invasion, and perineural invasion. So, regional lymph nodes, number, and how many are involved, how many are examined laterally, and size of the largest metastatic deposits. Also important is extranodal extension in case of head and neck tumor, especially in oropharynx, required especially in case of HPV unrelated or negative oropharyngeal carcinoma, whether they are present or not, and how much is the distance from the lymph node capsule. If it is greater than 2 millimeter, then it is taken as macroscopic extranodal extension. If it is less than or equal to 2 millimeter, then it is taken microscopic. And then pathological stage classification, ancillary study, and comments. So there are certain differences in the T staging of the oropharyngeal cancers between HPV positive and HPV negative. Let's see the differences. What the differences? So PTX is present only in case of HPV negative. Carcinoma in situ, which is not seen in case of HPV positive, so it is not included. 2 and 3 are similar for both of them. That is tumor dimension 2 centimeter smaller or tumor dimension larger than 2 but less than 4 centimeter. Coming on to P3, it is also same for both of them. Now the differences lies in T4. So in case of HPV positive, they are usually moderately advanced local lesion. Whereas in case of HPV negative, they are moderately advanced local disease or very advanced. So there is nothing like PT4A or B in case of HPV positive, but it is there for HPV negative. For the nodal status, the HPV positive oropharyngeal carcinoma has only N1 to N0 NX, N0 N1, where the number of lymph nodes are counted, whereas in case of HPV negative oropharyngeal carcinoma, whether the lymph nodes, the greatest dimension of the lymph node which is involved is also important, and whether there is extranodal invasion or not. For example, in N1, there will be ipsilateral lymph node 3 centimeter or smaller. In case of N2, it is divided into A, B, C based on the presence of whether the ipsilateral lymph node are involved or extranodal extension is present or not. So it is important point to note. So the status of cervical lymph node is single most important prognostic factor in aerodigestive cancer, and extension of metastatic tumor present within these lymph nodes through the lymph node and to the surrounding connective tissue, whether there is associated stromal reaction or not, it should be taken into account. And the distance of extension from the native lymph node capsule has to be stratified macroscopic or microscopic. These are not prognostically relevant for HPV positive, but they are very important for HPV negative and other nasopharyngeal carcinoma. So this is from my hometown. It's Fort of my native place. So people should not forget their roots. So with this, let's move on to the esophagus. So esophagus, it's a muscular tube. It's 25 centimeter in length. It begins at the level of cricoid cartilage, and it connects stomach to the gastroesophageal junction. So these dimensions like 15, 20, 25, 30 and 40 centimeters are the distance of the endoscope, which is inserted from the incisor to uh, the gastroesophageal junction. It counts to 40 centimeter. This is how the endoscopist measures, and it connects stomach to the gastroesophageal junction. Macroscopically or endoscopically, it is defined by Z line, which is present at the gastroesophageal junction, and the lower esophageal structure, which is site of increased muscular pressure. So before going to the histology, let's see the overview of the normal GIT histological layer. So it is comprises of mucosa, which is having epithelium, lamina propria and muscularis mucosa, which is followed by submucosa and glands within the submucosa, followed by submucosal plexus and muscularis propria, which has inner circular and outer longitudinal muscles, and beneath them they'll have myeltric or Auerbach's plexus and the serosa. So with this, the esophagus, coming on to the normal histology in the esophagus. So here the epithelium is non-keratinizing stratified squamous epithelium with few scattered intraepithelial lymphocytes present within them, which is called squiggle and Langerhans cells. The lamina propria contains blood vessels, inflammatory cells and mucous glands, and muscularis mucosa. These are usually thin longitudinal bands, but they are thicker at the gastroesophageal junction. The submucosa is a loose connective tissue. It has blood vessels, lymphatics, Meissner's plexus, and mucous salivary gland, which are more prominent in the upper and lower one third. The muscularis propria, which is inner circular and outer longitudinal, and presence of Auerbach's plexus, and there is presence of interstitial cells of Cajal between the muscle layer, which is better seen on CT117, from which gist arises. In case of esophagus, it lacks true serosa in most of the length. However, the adventitia here is just loose connective tissue partial sheets. So coming on to the non-neoplastic entities in the esophagus. So esophagus, just like oropharynx, can have heterotopia. So it can have a heterotopic gastric mucosa, and it is most commonly seen in the upper one third of the esophagus in the post-cricoid region. It is seen in 1 to 4% of the patients, and on an esophagoscopic examination, it will look as circular flat orange to red area, also known as cervical inlet patch. Microscopically, it will have a gastric gland of the cardiofundic type in the lamina propria or submucosal layer. Other heterotopic tissue can be pancreatic, which is also known as pancreatic acinar metaplasia. It's a congenital condition, and commonly seen in the gastroesophageal junction. And it is associated with advancing age, H. pylori infection, GERD, and female gender. The heterotopic sebaceous glands, which are seen in the middle dorsal portion of the esophagus, can also be seen. Zenker's diverticulum, which is commonly seen in esophagus, it's basically a false diverticulum because it has just mucosa and submucosal layer. It is an acquired mucosal herniation which is present between the horizontal and oblique fibers of cricopharyngeus muscle. So it is most common type of diverticulum seen in the upper aerodigestive tract, and the cause are abnormal pressure during swallowing causes dehiscence of this muscle, leading to the formation of this Zenker's diverticulum. So this is the gross photograph, which is showing inner mucosal layer. So other diverticula are traction and epiphrenic. Other congenital anomalies are esophageal atresia, tracheoesophageal fistula. These are atresia is commoner than stenosis, and these are usually associated with other syndromes like Bacter. They present as choking and respiratory distress in the first day of life, and on radiology they will have absence of normal gastrointestinal pattern. Pathologically, they will have atresia. These are usually associated with tracheoesophageal fistula in 85% of the cases. The stenosis is usually seen in middle third, and it is usually a membranous kind. Stenosis in the distal third usually will be due to tracheoesophageal remnant. Coming to the esophageal cyst and duplication. So, what is duplication? It is a GI malformation, which consists of multiple lesions. So, GI duplication most commonly seen is in the jejuno-ileal segment, and the second most common segment is the esophagus. So, Demick and Hardwick divides them into two groups: duplication and neuroenteric remnant. So, let's see the most common duplications. These are cystic or tubular replicas of a segment of the GI tract. They are directly contiguous with the segment with which they are associated, and any segment from the mouth to the anus may be involved. So there are certain histological criteria, like they should be attached to the esophagus, it should be enclosed by two muscle layer, and it should be lined by the epithelium. So this epithelium can be cuboidal, columnar to cuboidal layer, and heterotopias of any other GI mucosa may be also be present. And if a cyst wall is comprising of various other epithelial types of the GI tract, then it is called enteric cyst. So next congenital anomalies, neoenteric remnant, second one. So it basically originates from the dorsal midline of the GI tract and extends to the cranial direction. It attaches or passes through the vertebral column and spinal cord. So it can be in the form of cyst, it can be in the form of sinus, diverticula, or fistula, or fibrous cord. So in clinically they manifest as respiratory distress obstruction in the GI tract, peptic ulceration, and microscopically they are diagnosed as presence of this neural tissue present in the vicinity of GI tissue. Next is achalasia. So achalasia is a failure of relaxation of the lower esophageal sphincter when the peristaltic waves conveying the food through the esophagus do not reaches to the lower esophagus. So basic the pathogenesis is there is inflammatory destruction of the mesenteric ganglion cells, which are predominantly due to CD3 positive T cells. And histopathologically, we can see that there is loss of ganglion cells and widespread fibrosis of the mesenteric nerves. Esophageal varices, which are dilated tortuous veins present within the lamina propria submucosa. They form bulge into the esophagus lumen, and because the cause is portal hypertension and portal systemic shunt, they are seen in the distal 3 to 4 centimeters of the esophagus, and mostly they are associated with alcoholic cirrhosis. Histologically, they are seen as dilated submucosal veins, and they are usually associated with fresh hemorrhage or organizing thrombi. Mallory-Weiss laceration, these are longitudinal tears of the mucosa in the region of gastroesophageal junction. They are strongly associated with chronic alcoholism or NSAID use. The typical history is retching or forceful vomiting in case of 30% of the cases, and they are basically related to the upward diaphragmatic movement. So, in case of esophagus, esophageal bleeding is a very common clinical presentation, and these are the some list of entities which can cause the esophageal bleeding, like gastroesophageal reflux disease. They will be having heartburn, regurgitation present in the 40s, and the distal 7 centimeter of the esophagus is usually involved in the background of esophagitis. Herpes simplex virus infection will be present as odynophagia, and they are usually seen in case of immunocompromised patient. Here, the typical finding will be ground glassing nuclear inclusion in case of squamous cells at the edge of the shallow punched out ulcer. So it is important to look at the edge of these ulcers, but not in the surface or base. Candida infection has a clinical feature of substernal dysphagia. It is also seen in immunocompromised patients, and grossly they will have patchy white mucosal plaques. Microscopically, they will have neutrophils, pseudohyphae in the superficial squamous epithelium in the detached fragments. We will see microscopy of these things. CMD will have odynophagia. It will also be seen in immunocompromised patient, and these will have their typical single large nuclear and multiple amphiphilic cytoplasmic inclusion in capillary endothelial and stromal cells. NSAIDs will we have a clinical history of chronic NSAID intake. They will have shallow, large ulcer with broad base. They are usually seen in middle esophagus and devoid of any background esophagitis. Pill or medication-induced esophageal bleeding can be caused due to sudden onset, can be caused due to pills swallowed without fluid, example, antibiotics like tetracycline, quinidine. On pathology, they will have non-specific superficial desquamation, and there can be spongiosis, necrotic keratinocytes. Radiation induced, there will be have history of radiation, and there will be fibrinoid necrosis and dilatation of the blood vessels, and the vascular internal proliferation. Foreign body, most commonly seen in case of children, psychiatric patients, and chemical injury. So these will have non-specific necrosis, inflammation, and ulceration. Chemical injury can be also be due to alkaline ingestion damage. So this is herpes esophagitis. So this is an endoscopy. We can see that these are the ulcers with the central erythematous areas. And microscopically, we'll have typical ground glassing of epithelial cells. Fungal candidal esophagitis are usually seen when the candida are infiltrating. These pseudohyphae or yeast forms are present. The usual squamous cell will have dyskeratotic morphology, and these hyphae are usually seen at the edge of the gist keratosis. So whenever we see inflammation or dyskeratosis, these edge of the area should be screened for presence of esophagitis. Condenser, this it's very helpful. So let's see on to the inflammatory disorders of the esophagus. So esophagus will have can have three kind of pathology. Either they can be normal, inflammatory, or neoplastic. In inflammatory, it depends based on the presence of predominant inflammatory cells. Can be divided into eosinophilic predominant, neutrophil, lymphocytic, granuloma, or quasi-inflammatory. The most common causes. So we'll move on these one by one. Going to the eosinophilic predominant inflammatory pattern. So two most common entities are reflux esophagitis and eosinophilic esophagitis. Reflux is usually seen in case of GERD, patients with GERD symptoms. Eosinophilic esophagitis will have patients having allergy or asthma. They will more commonly present with food impaction. The typical endoscope feature will be there, like rings, linear furrows, and pH impedance in case of esophagus, eosinophilic esophagitis. And the mid and upper portion are more commonly involved in case of eosinophilic esophagitis. More than 15 eosinophils per high power field is important criteria for them. However, it should be correlated with other clinical findings as well. So other causes can be Crohn's disease, infection, hypereosinophilic syndrome, drug hypersensitivity. So let's move on to the primary eosinophilic esophagitis. It's a chronic immune antigen mediated disease, esophageal disease, clinically characterized by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. So these are mostly present in children and adults, and with a male preponderance. They will have a symptoms of feeding difficulty, especially in infants, nausea and vomiting and pain in case of children, and dysphagia in case of adults. And the dysphagia will more for the solid food. Other features will be chest pain, food impaction, and upper abdominal pain. So pathogenesis, it is because of T helper type 2 helper T cells and other mast cells, lymphocytes, serotaxin, interleukin 15, 13, and thymic stromal lymphoprotein are also responsible. So this is the endoscopic picture, where we can see the fixed esophageal rings, also known as trachealization or the ring esophagus, and the transient esophageal ring, also called as phenyl folds or phenylization. The mucosal plaques or exudates can also be seen, and longitudinal furrows are also characteristic of eosinophilic esophagitis. They can also have edema, diffuse esophageal narrowing, narrow caliber of the esophagus. So now coming to the histological findings. So histologically, they have major and minor criteria for the diagnosis. In major, there should be presence of increased intraepithelial eosinophils more than 15 per high power field in the most densely populated area. There can be eosinophilic microabscesses, which is known as collection of 4 or more eosinophils, surface layering of eosinophils, surface sloughing of squamous cells mixed with abundant eosinophil and extracellular eosinophilic granules deposition. So presence of major criteria is important. The supportive minor criteria can be marked basal cell hyperplasia, grade lengthening of the lamina propria papilla greater than 2/3, increased lamina propria fibrosis, chronic inflammation, increased intercellular edema, and increased intraepithelial lymphocytes and mast cells. So in this microscopic examination, we can see that there are more than 15 eosinophils per high power feed. In this, we can see eosinophilic microabscess, that is collection of more than 5 eosinophils, 4 and more than. And here we can see eosinophilic degranulations. So these are. So here a diagnosis, the bottom line should be given as active esophagitis characterized by abundant eosinophilia. And a note should be given that these findings are consistent with the eosinophilic esophagitis in the appropriate clinical and endoscopic setting. So this diagnosis is done only after presence of all the three. So it's based on clinical pathological correlation only. Next is a neutrophilic predominant inflammatory pattern. So it can be seen in infection like candida, and if it is present, search for the candida should be done where there will be surface hyperkeratosis and neutrophilic inflammation. CMV and herpes esophagitis are also other causes apart from pill esophagitis, radiation esophagitis, and corrosive mucosal injury. Lymphocytic esophagitis, it is histologically seen as a severe lymphocytic infiltrate in the peripapillary epithelium with presence of spongiosis in the epithelium. So causes are numerous, like Crohn's disease, GERD, infection motility disorder, allergy, asthma, autoimmune disease, celiac disease. Granulomatous esophagitis are usually caused by Crohn's disease or the most common mycobacterial infection, fungal infection, vasculitis, or drug induced. Quasi-inflammatory esophagitis are seen as apoptosis and necrosis in the absence of inflammation. So GVHD is most commonly present as quasi-inflammatory esophagitis. Also, in case of immunocompromised patient, when there is presence of infection, it will lack inflammatory response. So in those cases also quasi-inflammatory esophagitis can be seen. Amyloid deposit can also be one of the differential, which are usually confined in the blood vessels of lamina propria and superficial submucosa. So these are some of the differentials, and there are specific features by which they can be diagnosed. Esophageal ulcer, when there is presence of only granulation tissue without viable mucosa, in these biopsies they should be evaluated for viral inclusion, pill fragment neoplastic cells before giving as bottom line as non-specific ulcer. So next, move on to the gastroesophageal reflux disease. So its prevalence in India ranges from 7.6 to 30%. It's extremely common chronic condition in the Western countries. The risk factors are advancing age, alcohol consumption, increased BMI, and tobacco smoking. They have symptoms of heartburn, acid regurgitation, dysphagia. The contributing factors are hiatal hernia, defective or weak lower esophageal sphincter, impaired esophageal peristalsis with transient LES relaxation, delayed gastric empty, decreased salivary gland secretion, increased gastric acid production, and bile reflux. So there are, for the pathogenesis is explained by two concepts. One is classical, but there is another alternative concept is there. According to the classical concept, the reflux of gastric or duodenal fluid into esophagus causes the destruction of the protective mucosal barrier, which causes injury to the esophageal mucosa, and this ongoing injury causes inflammatory response in the form of neutrophilic infiltration and proliferative response in the form of basal channel papillary hyperplasia. But according to the alternative concept, which is recent and based on animal studies, after the acid reflux and reflux of acid and bile cells, the epithelial cells will secrete inflammatory cytokines like interleukin 8, 1 beta. These cytokines will call inflammatory cells to migrate to the epithelium, and this inflammatory cells will then damage the esophageal mucosa. So, and GERD is responsible for the Barrett's esophagus. So this is one of the pathogenesis, how this bile and acid causes the damage of the mucosal cells, and thereafter there is formation of rapidly dividing mucus secreting cells from the stem cells present in the basal layer of the esophagus. So on endoscopy, GRD will look like, so diagnostic biopsy specimen should be obtained by more than 2 centimeter above the G junction in order to diagnose esophagitis reliably, because all symptomatic patients should undergo biopsy regardless of presence or absence of endoscopic abnormalities. So because the changes are usually seen close to the gastroesophageal junction, so more than 2 centimeter is a reliable distance away from the GE junction from which microscopic changes can be seen, and histological features of untreated active esophagitis will be seen as basal cell hyperplasia, elongation of lamina propria more than two-thirds, epithelial cell necrosis, increased intraepithelial inflammation by eosinophils, neutrophils, lymphocytes, lack of surface maturation, so there will be nucleated cells at the surface, distended pale or squamous balloon cells, intercellular edema, acantholysis, and in severe cases there will be surface erosion or ulceration. So this is the normal squamous mucosa. Here the basal and suprabasal cells are present only in less than 15% of the thickness, and the lamina propria papilla is present up to the 50% of the thickness. Whereas in case of reflux esophagitis, the basal and suprabasal cell hyperplasia will be there, and there will be elongation of the lamina propria papilla. The most important thing in this is the bell orientation of the tissue, and it should include, we should look for at least 3 consecutive papilla before proper and correct interpretation of these length and proportion of the according to the thickness of the epithelial layer. So in GERD there can be presence of eosinophils, neutrophils. So eosinophils can be few or normal in distal one-third, and they are rare in intraepithelial eosinophils, and presence of eosinophils is very important in case of children. So even rare intraepithelial eosinophils are diagnostic of reflux esophagitis, and whenever eosinophils are present even in lamina propria, it is very sensitive indicator of GERD in infants. Neutrophils are always indicator of pathologic process in esophageal biopsy, and they are although seen in less than 30% of the cases, but with surface erosion and ulcer, we should always look for candidal infection apart from GERD. So there will be dilatation and congestion of the lamina propria capillaries, and balloon degeneration of squamous cells, intercellular edema. So this is microscopic photo which is showing presence of neutrophils in the epithelium. These are presence of lymphocytes with the presence of spongiosis in the layer, and here there is presence of eosinophils in the epithelial layer. Here we can see that there is hyperplasia of the basal and suprabasal layer, and there are presence of these lymphocytes. Here also there is a presence of basal and suprabasal cells in the upper part of the epithelium. There is balloon degeneration of the epithelial cells, which is better appreciated on this closer view, where upper and middle portion of the epithelium is comprising of balloon epithelial cells, squamous cells. Also in GERD, we can see multinucleated cells. The importance of it is important to differentiate these multinucleated cells from HSV. These will present in the basal aspect, but not in the superficial. So in case of GERD, these multinucleated giant cells will be present in the basal aspect of the lesion, or the edge or up in the below the ulcer, but not in the superficial aspect. So what are the differentials? Infectious, pill, primary eosinophilic esophagitis we have seen, and the diagnosis of active esophagitis consistent with reflux should be given rather than a straightforward diagnosis of reflux esophagitis. So how to differentiate from reactive hyperplasia versus dysplasia? So papilla in case of hyperplasia will be regular, whereas in case of dysplasia it will be absent or irregular. In dysplasia there will be nuclear enlargement, piriform morphism, overlapping hyperchromasia, and irregular nuclear membrane. So after this, let's move on to the neoplastic esophageal pathology. So on WHO classification 2019 divides esophageal tumor into benign and malignant epithelial tumor and their precursors. In the benign we have squamous cell papilloma, esophageal glandular dysplasia, both low high grade, and squamous intraepithelial neoplasm, both low and high grade. So and this is the TNM classification and the pathological staging. So again, we can see that there are number of the lymph nodes rather than the size of the lymph nodes which are important. So this is the T and pathological. This is the diagrammatic representation to see. So T1A is the intramucosal carcinoma when it invades the lamina propria or muscularis mucosa. T1B when the tumor invades the submucosa. T2 is when it invades the muscularis propria. T3 when it invades the adventitia. T4A when it invades the pleura, pericardium, azygous, diaphragm or peritoneum, and T4B when it invades the adjacent structures like aorta, vertebral body or airway. So according to AJC 8 edition and according to WHO, so tumor which are involving the esophagogastric junction that have midpoint within the proximal 2 centimeter of the proximal stomach or cardia are to be staged as esophageal cancer. Whereas, and the cancer whose epicenter is more than 2 centimeter distal, they are, even if it is esophageal junction is involved, they should be staged as stomach cancer based on TNM and stage groupings. Again, in case of esophageal cancer, regional lymph nodes are important, and esophageal drainage area, including celiac axis and paraesophageal nodes in the neck, should be taken into account, but not the supraclavicular lymph nodes. If a supraclavicular lymph node is involved, it is a distant metastasis rather than regional lymph node involvement. So lymphatic channels in case of esophagus are important because they are present in the entire layer of the esophagus, including the lamina propria, but they are more concentrated into the submucosal layer, and they in the submucosa they are present in the longitudinal nature. So originally, so if any tumor present anywhere in the esophagus, it especially in the submucosal layer, it can move on to the other parts of the esophagus. So occasionally skip lesions are present, which are possibly due to longitudinal lymphatic spread. If there are multiple discrete lesions, the tumor length has to be measured from the top of the highest lesion to the bottom of the lowest lesion. So that is important for T. A little bit about the esophageal grossing. So after the endoscopic biopsy, whenever at the grossing, when the endoscope is sent at that time itself, the esophagus, the endoscopic biopsy should be put on a filter paper. It should be pinned in the periphery for the proper orientation, and then only the proper orientation of all the endoscopic biopsies are very important. Then only in our lab or during embedding and cutting, a proper oriented biopsy with epithelium, lamina propria and submucosa can be seen. For the grossing of larger specimen of esophagus, we should first see the radiological findings, whether what is the site and what is the extent or the focality of the tumor. And at the grossing station, we should locate the tumor before opening, and we should paint the adventitial surface of the esophagus where the tumor is present, and cut should be given away from the tumor end. The sections should in tumor, the margins, GE junction, and other suspected areas of tumor. So coming to the neoplastic, so first is a squamous papilloma. It's a benign epithelial polyp. It is composed of squamous epithelium with papillary growth. Usually it is seen in middle in the Asian population. Clinically it is usually asymptomatic, and on endoscopy it's seen as small white exophytic growth with vessels crossing the wall. It is usually 3 millimeter in diameter, and it is rare and seen in around 50 years of age with the equal male to female ratio. The etiology is a chronic mucosal irritation due to GERD alcohol, or can be mechanical due to trauma or chronic food infection. HPV infection is seen, and it is also associated with genetic syndrome like focal dermal hypoplasia or angioma sulfidism. On histopathology, we can see papillary proliferation of the squamous epithelium with the presence of fibrovascular cores. There are no atypical features or nuclear features or viral inclusion. The differential diagnosis is fibrovascular polyp of the upper esophagus. However, the papillary proliferation is absent. So the essential diagnostic criteria is papilloma consisting of squamous epithelium with fibrovascular core, and they don't recur and they rarely transform into squamous cell carcinoma. Now coming to the Barrett's esophagus, so Barrett's is a conversion of normal squamous epithelium of the esophagus into the metaplastic columnar epithelium. So it is Barrett's has given different definition from different societies, like American College of Gastroenterology say endoscopically recognizable columnar metaplasia of the esophageal mucosa. So they use two modalities for first on recognize the columnar metaplasia, and then they will confirm by microscopy to contain intestinal goblet cells. The British and Japanese, they don't require intestinal metaplasia to establish a diagnosis of Barrett's esophagus. They need just esophageal columnar epithelium, which can be seen on endoscopy. So although these columnar cell epithelium has physiological properties of intestinal differentiation, like they do express HAPAR1 billion -1 Mark 3, and in most patients with at least 2 centimeter of columnar line esophagus are found to have intestinal metaplasia. So the differences between the presence of goblet cells is actually it it is only the sampling error which is important. So like if the lesion is like 4 centimeter or 6 centimeter, the chances of getting goblet cells within the biopsy are more than in compared to the size, the lesser like 2 centimeter size of the lesion. So on endoscopy, the G junction is the distal extent of the palisading vessels, which are seen as fine longitudinal veins. So how endoscopy, and these are located in the lamina propria of the distal esophagus. Squamocolumnar junction, which is also known as a Z line, is the junction of squamous and columnar mucosa. So columnar mucosa on endoscopy look like salmon pink color. The endoscopic should provide the pathologist the knowledge about the relationship between squamocolumnar junction and gastroesophageal junction. So gastroesophageal junction is fixed, whereas the squamocolumnar junction is what is the abnormal or pathological finding. So, and Barrett's esophagus have a risk of cancer 30 to 125 times greater in comparison to the non-Barrett mucosa. So on endoscopy, how it looks like. So this is the normal Z line. So this is salmon pink colored gastric mucosa, and the the periphery is the squamous lined esophageal mucosa. In case of Barrett's, what happens is there is called columnar metaplasia into the anus epithelium, and which is also seen microscopically here and see here. So let's move on to the Barrett's intestinal metaplasia. So intestinal metaplasia can be incomplete or complete. In case of incomplete, it may have just goblet cell. In case of complete, it will have both goblet cells and there will be presence of brush border or microvilli throughout the epithelial layer. So for recognizing goblet cells, they are usually goblet shaped. They will have basophilic secretions, mucoid secretions present in them, and they are usually present far away from each other. So they are present in alone, or they are not present in groups. So it is important to recognize them. So these are round goblet shaped. They are present in the superficial epithelium or in the crypts, and they are randomly distributed. Whereas pseudogoblet cells, they are elongated distended cytoplasmic vacuoles. They are usually seen in the superficial epithelium. They are rarely seen in the crypts, and they are linear or non-random distributed. So example of fake goblet cells or pseudogoblet cells are these. So these are present in the superficial layer. They are present in the groups, and on PS Alchin blue, they can be easily highlighted. Whereas these are the real goblet cells, which are present in a randomly distributed area, which are staining blue at PS Alchin blue, highlighting them to be acidic mucin. Also, these are submucosal glands, which are also not a goblet cell. They are present in collection. So Barrett's mucosa has a neoplastic categories. It is like negative for dysplasia, indefinite, low grade dysplasia, high grade, intramucosal carcinoma, that is PT1A, and invasive adenocarcinoma, that PT1B, but it involves the submucosa. So let's see Barrett's mucosa negative for dysplasia. So it will have surface maturation, a bundle amenopropria, it lacks distinct atypia. There will be normal chromatic small bland nuclei, intact nuclear polarity, and inflammation will be proportionate to the atypia. So this is Barrett's esophagus negative for any dysplasia. So there are presence of this columnar shaped lining with randomly placed goblet cells. Now, Barrett, low-grade dysplasia in Barrett mucosa, this will lack surface maturation. There will be distinct atypia. There will be abrupt transition, hyperchromatic nuclei, large with pseudo-stratified nuclei can be present or not. Nuclear polarity will be intact. There will be liftil or no architectural atypia. They are usually managed by expert. So this is abrupt transition between the normal lining, columnar lining, and the low-grade dysplastic lining, and these are the goblet cells. So these are the intestinal type of metaplasia, and this is the gastric type of metaplasia. Here again, the cells are present showing a pseudostratification. Or foveolar metaplasia, the cells will have round nuclei than in comparison to the intestinal metaplasia, which have the more of a elongated hyperchromatic nuclei. So foveolar gastric metaplasia will have dysplasia will have more of abundant mucin within the cytoplasm. Now moving on to high grade dysplasia, all the features of low grade dysplasia will be present. Additionally, they will be out of proportion of inflammation, and they will have architectural abnormality. Crypts will be of variable size and shape. There will be full thickness nuclear stratification, increased mitosis, and including atypical ones. So again, here we can see that there is nuclear stratification and presence of nucleus up to the surface, but there is abrupt transition. This is high grade dysplasia. This is intestinal type and this is gastric type. So dysplastic Barrett's can also be present in the inflamed region. Here we can see that these cells have reached up to the surface. So this is inflamed Barrett's with high grade dysplasia. Then intramucosal carcinoma in Barrett's mucosa. So all features of high grade dysplasia will be present. Additionally, it will have luminal necrosis, back-to-back glands, and prominent nuclei. And atypia will be out of proportion to the inflammation. So this is the normal squamous lining, and this is the intramucosal carcinoma. So we can see that presence of this back-to-back glands, and these are having luminal necrosis within them. So Barrett's mucosa with basal crypt dysplasia. Here the dysplasia will be atypia will be restricted to the base, and this is one of the example. Here only the basal crypt is showing dysplasia. Then there can be instances when it is difficult to differentiate the Barrett's mucosa whether there is presence of dysplasia or not, and in those cases a very good article from Waters et al. In 2018 is given. So negative for dysplasia will have 4 lines. So what are these lines basically? So non-dysplastic architecture will be having 4 lines. Line 1 will be having gastric type, represent gastric type mucin vacuoles. Line 2 will represent base of these mucin vacuoles. Line 3 will represent the cytoplasm of these mucinous cells, and line 4 will represent the nuclei of these mucinous cells. So a negative for dysplasia tissue will have all these 4 lines, whereas a dysplasia will lack these 4 lines. And when the problem, and when there is in between, then it is indeterminate for dysplasia or indefinite for dysplasia entities. So these are various morphological spectrum of Barrett's esophagus, and these are how they are managed. So non-dysplastic Barrett's will have repeat biopsy in 3 to 5 years. If a biopsy is given as indefinite for dysplasia, optimized PPI therapy will be done, and repeat Luminoscopy will be done and it will be confirmed by biopsy in 1 year. And if it is discordant, then managed with new histology. If it is confirmed low-grade dysplasia, then endoscopic eradication therapy is done. Confirm high-grade, again endoscopic. So all these entities will have endoscopic eradication therapy, whether there is a esophageal intramucosal carcinoma as well. So so next move on to endoscopic mucosal resection. So basically these are excised as an endoscopic mucosal resection, and where it should be approached in a stepwise manner. So first we should identify the layer, identify the margin, assess the Barrett's and dysplasia, and see whether invasion is present or not. Assess for poorly differentiated component LVI, deepest layer of invasion, evaluate margin and look for other diagnoses. So like in this biopsy, so it is well-oriented biopsy, and first we should identify the layer, so mucosa, which is having epithelial layer, lamina propria and muscularis mucosae, and below the muscularis mucosae will have submucosal layer. Submucosal layer will have thick-walled blood vessels or submucosal glands. Sometimes there happens a problem like duplicated muscularis mucosa is there. It is due to chronic injury, repetitive chronic injury. So we should always look for the signs of submucosa properly. So there has to be proper thick walled blood vessels to say whether this is submucosal layer. And the most deepest margin is the submucosa should be present in the deepest layer. So how to identify the margin? So usually in a perfect world, we should get a biopsy something like this, where it's proper demarcation between all the layers, and the deepest margin should be submucosal layer and lateral margin should be like this. But in reality, in the endomucosal resection, we get biopsy something like this, where submucosa is like this and the lateral margin is bent. So how it is? Let's see with the video how endoscopic mucosal biopsy is taken. So this is the esophagus, lumen of the esophagus. This lesion present, and endoscopist has inserted the endoscope, and this endoscope will come, and it will inject either a normal saline or other substances to elevate the submucosal layer, and then it will be retracted, and a clamp and a snare will put to detach this mucosal lesion. So this is how endoscopic mucosal biopsy is obtained, and that's why how we can recognize that why we are getting biopsy something like this. So at the where the endoscopy is performed there itself, the biopsy should be put on the filter paper or a proper mounted tissue, and it should be expanded, properly retracted with the help of pins and stabilized. So what are submucosal landmarks? So it is usually present beneath the muscularis mucosa. The submucosa will have large caliber vessels and submucosal glands. So another example, so the deepest layer, there is a presence of submucosa, and there are thick walled blood vessels present in the submucosa, and these are the lateral margins. So whenever biopsy, we should paint the deepest margin, or we should see carefully in the microscope the deepest margin and the lateral margin, because these are important to confer in the report. Another example, here are the submucosal glands and the thick walled blood vessels in the submucosa, and this is the mucosal layer. So this is the deepest margin, these are the lateral margins. Okay, so just few more things to go. Yeah, almost looks exhausted. So Barrett adenocarcinoma. So it originates. So it's what are the essential diagnostic features? There has to be evidence of glandular or mucinous differentiation within an invasive tumor. And a desirable diagnosis, IHC has to be done in case of poorly differentiated carcinoma. So there are usually most commonly presented dysphagia, reflux, weight loss or pain. Their incidence is highest in the North America, Europe, Australia and New Zealand. In India, it is the second most common esophageal cancer after squamous cell carcinoma, seen in around 20% of the cases. However, it is on an increasing trend. The age is seen is the seventh decade with the male preponderance. So risk factor, the most common risk factor is the GERD, obesity, male sex and smoking. There are some protective factors like Helicobacter pylori infection and SID and some dietary factors. Microscopically, it looks like irregular plaque or small nodule, and in the early phases, and in the later phases it will look like fungating or ulcerative or diffusely infiltrative lesion. So these are the various morphological patterns which we can get. This is a tubular pattern, this is the papillary pattern with the prominent fibrovascular core, this is the mucinous variant of adenocarcinoma, and this is the signet ring cell adenocarcinoma. So now in adenocarcinoma, HER2 immunostain should be done to see the ERBB2 status. This is on immunohistochemistry and this is on SHISH. So adenocarcinoma has to be graded and it should be differentiated based on the if it has more than 95% of well-formed gland, moderately differentiated if 50 to 95% of well-formed glands are present, and poorly differentiated if it has less than 50% of the well-formed glands are there. These days, the esophageal specimens are sent to us after post-neoadjuvant chemotherapy, and for them tumor regression grade has to be done because they are important for the prognosis point of view. So there are Mandard and Becker, but both have their advantage and disadvantage. But Becker is more representative and it has got less inter-observer deviation. Accounts for only amount percentage of the carcinoma cells present. So TRG1A, where there is no carcinoma present, so that's the best response. TRG3, when there are more than 50% of the carcinoma cells are present, is the poorest response. So what are the post-therapy changes? So changes can be in stroma, nuclear or cytoplasm. In stroma, it can be fibrosis, mucinous change, dystrophic calcification, necrosis, inflammation, foamy or eosinophil-related macrophages, foreign body giant cell, cholesterol plebs, reactive changes in the fibroblast, glands, vessels, or arteriosclerosis. In the tumor nucleus, remnant tumor nucleus, there can be hyperchromasia, pycnosis, karyorrhexis, enlargement, nuclear irregularity, vacuolization, apoptosis, or necrosis. In tumor cytoplasm, there can be vacuolization, clear cell change, oncocytic change, neuroendocrine change, or tumor giant cells. So these all changes can occur in case of post-chemotherapy specimens. This is the scoring of HER2 in case of a GI adenocarcinoma. It is different from a breast adenocarcinoma because here only basolateral positivity is seen, but not the uniform whole circumferential positivity is seen. So here score 0 to 3 are given, and 0 means no reactivity. 1 is more than faint partial membrane positivity in 10% or more cells, and 2 is equivocal when 10% or more tumor cells show weak to moderate lateral or complete basolateral membrane reactivity, and 3 plus when 10% or more tumor cells show strong base lateral or complete basolateral membrane reactivity. So only 3 plus is straightaway positive, and 2 plus is equivocal, 0 and 1 are negative. So adenocarcinoma on IHC, it will be positive for CK7, CK19, negative for CK20, CK56, P63. So what are the adverse? There are certain adverse pathological factors like tumor size, higher grade submucosal invasion, poor differentiation, budding, which is called detached or isolated groups of 1 to 5 cells, presence of LVSI margin involvement. Treatment, they are treated by cisplatin, fluorosyl, trastuzumab if they are HER2 positive, and pembrolizumab if there is PD-L1 overexpression. Now coming to the dysplasia, so the essential diagnostic criteria for squamous dysplasia is there should be cytological ATP as well as architectural ATPs. In cytological ATP, there should be nuclear ATP and enlargement. pleomorphism, hyperchromasia, loss of polarity, overlapping. For architectural atypia, there has to be abnormal epithelial maturation. This squamous dysplasia can be low grade or high grade based on the involvement of how much portion of the epithelium is involved. However, so if only lower half of the epithelium is involved and only mild cytological atypia is present, then it is low grade. However, in case of high grade, severe cytological atypia, if it is present, then the extent of epithelial involvement is not considered. So that means if it is less than half or lower than half of the epithelium is involved, but the cytological atypia is severe, again it will taken as higher grade but not a low grade. So this one is the squamous dysplasia of low grade, which is involving the lower half of the squamous epithelium. Whereas here there are more than half of the epithelium is involved, and there is increase. There are higher nuclear abnormality. So for residents, it is important to differentiate between what is reactive and what is dysplasia. So these are two figures. So what all things we should see. So for dysplasia, there can be dyskeratotic feature also, which is seen here. So dyskeratosis is a pycnotic nuclei with apoptotic cells. In case of to differentiate between squamous dysplasia and reactive changes, the things to see are nucleocytoplasmic ratio, nuclear polarity, chromatin, nuclear membrane, and surface maturation. So in case of reactive, the NC ratio will be maintained as seen in both of these figures, where the NC ratio is high in case of below figures. The nuclear polarity is well maintained, that is, these cells are orderly placed in both the cases, whereas here the nuclear polarity is lost, that is, the nucleus is trying to settle here and there, like in here as well. So chromatin in case of reactive atypia will be more of a opened up chromatin or a ground basic chromatin. Whereas in case of dysplasia, most commonly it is hyperchromatic. Nuclear membrane are regular in case of reactive atypia, it is irregular in case of dysplasia. Maturation, surface maturation is usually preserved, like here. The squamous cells, as they are proceeding towards the top, they are maintaining their squamous maturation, whereas in case of dysplasia, the surface maturation is absent. So on endoscopy, narrow band imaging and Lugol's chroma endoscopy are helpful to identify grossly these squamous dysplasia. So narrow band imaging basically uses green and blue fluorescence, which highlights the RBC and hemoglobin better, so they can appreciate. And on Lugol's chroma endoscopy, the regions which are not stained, these are the dysplastic regions. So for pathogenesis, there is overexpression of P53 and hypermethylation of cyclin D dependent kinase 2. And these dysplastic squamous dysplasia have a chance of squamous cell carcinoma in when there is mild, moderate, and severe dysplasia, 5, 27, and 65%. So now let's move on to the squamous cell carcinoma. So there are essential diagnostic criteria. There has to be histological evidence of vertical and horizontal growth of neoplastic squamous epithelium, which has keratinocyte type with intercellular bridges or keratinization, with definite evidence of invasion. So the risk factors are low socioeconomic status, tobacco use, alcohol consumption, drinking very hot beverages, pickled vegetables, increased BMI, genetic factors, and some medical causes. So usually squamous cell carcinoma is seen most commonly in the middle one-third and in the lower one-third. So clinical features most commonly are they have a dysphagia in advanced stage and chest pain, odynophagia, weight loss, persistent ulcer and stricture. So esophageal squamous cell carcinoma is the sixth cancer related death, responsible for 6 cancer related deaths worldwide, and in India 80% of the esophageal carcinoma are seen in the form of squamous cell carcinoma. It is most common in male and usually present in the 7th decade. So we can see these, the dark color which are seen in this Southeast Asia, India region, and in the African belt. So what is the pathogenesis? So TP53 is the driver mutation which causes squamous cells to transform into dysplastic squamous cells. In this plastic squamous cells, there will be aneuploidy copy number alteration, EGFR amplification, NCD cyclin D silencing, and this will transform into the squamous cell carcinoma when there is epithelial myoepithelial transition, epithelial mesenchymal transition by amplification of EIF5A2 gene. So squamous cell carcinoma has to be graded. It is based on certain microscopic features. So it is well differentiated when the cells are enlarged with abundant eosinophilic cytoplasm, keratin pulp formation, minimal cytological atypia, low mitotic rate, invasive margin which is pushing, well ordered cells, moderately differentiated when there is infrequent keratin pulp formation, evident cytologic atypia, less ordered cell arrangement, easily identifiable mitotic figures and surface keratosis, and poorly differentiated when it is predominantly basal cell line, with presence of very occasional or few parakeratotic or keratinizing cells. The architecture usually seen in poorly differentiated squamous cell carcinoma is nesting with central necrosis sheets of pavement-like. They have brisk mitosis, including atypical mitotic figures. So, squamous cell carcinoma invasion is the most difficult, and generally pathologists find it very difficult. So, what are the signs of true invasions? So, there has to be like deep aberrant keratinization, like pinking up. So, something keratinization which is present in the deeper layer is a surest sign of true invasion. The presence of single infiltrating cells with atypical nuclei, the base membrane border appears ragged or deranged, and in case of well differentiated squamous cell carcinoma, which can acquire a prominent nuclei, and it can mimic reactive nuclei, but should have architectural features of invasion, like present in this case. So all things should be considered to say whether there is true invasion or not, and even if there is doubt, then serious invasion. So this abrupt keratinization is an important feature which we should look for. So microscopic classification of squamous cell carcinoma has been done by Japanese Esophageal Society, and it has two types, early and advanced. So type 0 and 1 are superficial and protruding type, and type 2 and 3 are advanced ones, which are ulcerative, localized, infiltrative, or diffusely infiltrative. So there are certain subtypes. So common ones in esophageal squamous cell carcinoma are verrucous, spindle cell, and basaloid. So verrucous carcinoma will have a invasive front, microscopically broad bulbous pushing projections. In case of spindle cell squamous cell carcinoma, it usually presents polypoid growth pattern with biphasic cells, and may show osseous or cartilaginous changes. The basaloid squamous cell carcinoma has marked male predominance. It is seen in solid or nested growth pattern with comedonal necrosis. It is highly aggressive and has worse prognosis. So just like esophageal adenocarcinoma, esophageal squamous cell carcinoma will also have certain post-chemotherapy changes, but the important ones, the differentiating ones are dystrophic calcification, foreign body giant cells, and arteriosclerosis. These foreign body giant cells and dystrophic calcification are due to dead squamous cells which have from which the keratin comes out within the interstitium, and it causes foreign body giant cell reaction. Apart from other features which I've already told. So other rare carcinomas are adenosquamous, which are usually seen in mid-esophagus. So they have distinct squamous and adenocarcinomatous component. There will be absence of intermediate cells, and true glandular or mucal cell differentiation will be present. According to Japanese classification, more than or equal to 20% of either of the component has to be there to say accurately as adenosquamous carcinoma, but there is no proper consensus for this proportion of cells. For mucoepidermoid carcinoma, they are mostly seen in mid and lower esophagus. There has to be intermediate cell, mixed glandular and squamous cells, true glandular or mucous cells differentiation. Both tumors are very aggressive and they are rare. Other rare tumors of esophagus are adenoid cystic carcinoma. They must have a distinct histological pattern, just like triple-formed tubules or nesting, with presence of both epithelial and myoepithelial cells, with presence of basophilic secretion. And if there is a difficulty in diagnosis, Like in case of small biopsy showing only basilar differentiation, then IHC or rebiopsy can be done. Undifferentiated carcinoma, in undifferentiated carcinoma, malignant cells will show no evidence of any differentiation by histologically or by IHC. They are usually seen in the lower esophagus. The neuroendocrine neoplasm, there we have morphological criteria which should suggest neuroendocrine differentiation, and it must be confirmed by IHC by demonstrating a specific lineage like chromogramin A or synaptophysin. So neuroendocrine neoplasm can be neuroendocrine tumor, neuroendocrine carcinoma, or mixed neuroendocrine non-neuroendocrine neoplasm. They are usually located in the lower esophagus with a male predominance, and they originate from the endocrine cells of the submucosal glands. Histologically, neuroendocrine tumor have insular or cribriform pattern. Neuroendocrine carcinoma, more than 90% of all the neuroendocrine tumors are seen by neuroendocrine carcinoma, and this neuroendocrine carcinoma is differentiated into small cell and large cell. So with this, I thank you all.
Wonderful. Very nicely presented. Very extensive.
Yeah, it was very extensive.
But the best part of it is I should congratulate you that you have covered almost every part of it. Nothing has been left, and everything has been detailed out, right from the staging, even showing a video, exactly how the biopsy is done, endoscopic mucosal resection biopsies, the orientation, the grassing. Very, very well done, Dr. Ojas. Excellent job. Very well done. God bless you.
Thank you, sir. Thank you so much, sir.
Right. I think there are no questions, and I think you must be very tired. If there are any questions, I'll put it up in the group, in the Telegram group. You can take it from there.
Sure.
Okay,
Sir,
then.
Sure.
Thank you. Then good night. Bye-bye. Take care. Bye.
Thank you, sir. Thank you so much.
Thank
Bye.
you. Bye-bye. Bye.